With everyone's permission, I'm starting with today's session now.
Can we start now?
Yes, ma'am.
Mahesh sir? Sir, ಶುರು ಮಾಡೋಣ ಪ್ರಕಾಶ್ ಸರ್ ಆನಂದ್ ಸರ್.
Yes, ma'am. Yes, ma'am. We are ready.
Okay.
Yes, madam. Yes.
Greetings. Greetings and a warm welcome to all the dignitaries present here. I'm Shwastika from Team Clarinet, serving as an allocated session assistant to ensure a seamless experience. Clarinet is India's most trusted and widely used digital platform, offering a multitude of enriching services exclusively for the doctors. Clarinet is delighted to be chosen as a digital partner for this event organized by Karnataka Undergraduate and Postgraduate Ophthalmology Teachers Academy, KUPOTA. So today's focus would be online educational series episode 1. Let's begin today's session, for which I would like to invite Dr. Soma ma'am to take over. Over to you, ma'am.
Thank you, Swastika. Good evening, respected senior teachers, colleagues, friends, and dear postgraduates residents. I am Dr. Soumya HV, Professor and Head of Ophthalmology, JSS Medical College and Hospital, Mysuru. Very happy and excited to moderate the inaugural session of Online Educational Series, a novel initiative of newly formed Karnataka Undergraduate and Postgraduate Ophthalmology Teachers Academy. Happy to be one of the founder member of this initiative, thought of, born, and now being nurtured by like-minded clinicians for robust academics across the state. Happy to have another founder member, Dr. Mahesh Babu, along with me, Professor and Head of Ophthalmology, Subaya Institute of Medical Sciences, an academician, clinician, and researcher who has been a strong pillar for this very initiative and has pioneered many such academic programs in the state. Today, we are not merely launching an online academic session, we are initiating a structured, mentor driven learning ecosystem for ophthalmology students across Karnataka. The core vision is to create uniform, high quality academic standards in postgraduate and undergraduate ophthalmology training across the state. The Academy aims to strengthen clinical reasoning and presentation skills among postgraduates to create a culture of academic rigor and not passive listening, and to ensure that a postgraduate in one corner of Karnataka receives the same intellectual stimulation and academic exposure as one in any major academic center. Over time, this platform can reduce variability in postgraduate competency, enhance exam preparedness, foster research thinking, and build confident future academicians and good clinicians. The sessions would comprise of case presentations, journal clubs, competency skills, quizzes, and lot more. We also plan to have programs at the undergraduate level also to enhance their learning in ophthalmology and make them better Indian medical graduate. Today's session is the first step towards that long-term academic harmonization. Let us make this interactive, rigorous, respectful, and growth-oriented. I now call upon Dr. Mahesh Babu to kindly take over the proceedings and kindly bear with my voice. Thank you.
Thank you, madam. Thank you for that kind introduction. Good evening, everyone, respected faculties, teachers, discussants for the session, and also the delegates, postgraduates who joined this session. So we will like to make it very interactive. So I request all of you to kindly, any questions if you have, post on it. So without much delay, I would like to proceed with introduction of all our panelists here. First of all, we have our chair for this session today, Dr. Anand G. Gannur. Sir is a professor
Thank you,
and
sir.
HOD at AMC Medical College, Bijapur. And sir is specialist in vitreoretina. And sir, one pioneer thing is sir has started first VR setup in Vijayapura district. So
Thank you,
I
sir.
welcome you, sir, and thank you for accepting to be the chair for this session. Welcome you, sir.
My pleasure.
And
Thank you, sir. My pleasure.
before moving on to the next discussions, I would like to tell all of you that all the, whether it is chair or the discussants or the mentor, all here have got vast clinical experience, academic experience, as well as teaching experience. So we are having great mentors here. So again, I request all the delegates, supposed students, to please make use of this platform. Next, we have with us our discussants, Dr. Kavita CV, madam. She is She has served as professor in Hassan Institute of Medical Sciences and HOD as well. Now, other than that, she is taking up the role of administration. Now, Madam is a principal in Hassan Institute of Medical Sciences. Thank you, Madam, for sparing time for us and being part of this session. Welcome you, Madam. Now we have Dr. Prakash DN sir. He is my teacher at Mysore Medical College. Happy to introduce sir here. Sir has served as professor in Mysore Medical College for a long time. Has been mentor for so many of us. Now sir is serving as professor in Adi Chunchanagiri Institute of Medical Sciences, Belluru. Thank you for being part of it, sir. I welcome you.
Thank you, Mahesh.
Thank you, sir. Next, we have Dr. Bindu Malini MH. She is assistant professor in ophthalmology at JSS Medical College, Mysore, and she is specialized in orbit and oculoplasty. Madam, we welcome you for joining the session, and thank you for accepting the invite.
Thank you so much, sir, for including me here. Thank you.
Okay. Now we have our mentor, Dr. Chinmay, Madam. She is professor in ophthalmology, Regional Institute of Ophthalmology at Minto, Bangalore, and her interest is a very wide range of interest she has, starting from strabismus. She's doing oculoplasty, orbit, neurophthal. Madam does everything, whatnot, and she's one of the most sought after teachers in yeah, many of our students, and they have passed out almost 10 years back. Still, they remember her as very, good mentor and teacher, and even a younger elder sister and friend as well. Thank you, madam, for mentoring the session. I will.
Thank you, Dr. Mahesh. Thanks a lot for the wonderful introduction. And I'm very happy to be part of this team. Thank you.
And now we have with us presenter for Dr. Karishma Dasari. She is a final year postgraduate student at Minto Ophthalmic Hospital and Regional Institute, Bangalore. She has put in a lot of thank you, Dr. Karishma, and welcome. And I hope we have a very good and interactive session here.
Thank you so much, sir. It's very grateful to have such a good opportunity for us to present and to learn things through this academic session, sir. Should I start presenting, sir?
I think Mahesh sir, it's not audible. Mahesh sir?
Anand sir, can you hear me?
Yes, sir. And now it's
Yeah.
audible.
Sir, I would request as a chair to say a few words, then we'll proceed to presentation proper.
Okay, sir. First of all, it's a privilege for me to be part of this great initiative. That is, I mean, entire team I have to congratulate, including Dr. Mahesh sir, Soumya madam, Kavita madam, Prakash sir, Bindu madam. I mean, everyone, including the PG students. All of us, we know the need of such kind of events that is necessary for our PGs, including our own self to upgrade our knowledge. It's a great initiative. I think more and more PGs are going to join in the next future sessions, and more staff from other medical colleges are going to join as well. Let this grow bigger and bigger. Let this initiative grow. Let other states also copy this kind of initiative. Let it be useful to all PGs as well as staff. So all in all, I'm going to wish entire team a great success. And without taking much time, I would like to switch on. I mean, request our moderators to take on the session further. Thank you, sir.
Thank you, sir. Thank you so much. Now, I would request Dr. Karishma to start over the presentation, and I would like all the discussants and mentor to take the center stage. Thank you.
Good evening, all. I'm Dr. Karishma from Minto Ophthalmic Hospital. So today I'll be presenting a case, clinical case presentation on proptosis. Sir, is my screen visible?
Screen is not yet visible.
Not yet visible.
Can you please share it?
Yes, sir. Is it now visible, sir?
I think you have not still shared, I guess.
Is not yet visible.
Is it visible now, sir?
Yeah. Now it's being visible. Yeah.
Yes. Yes.
Fine.
Yes.
Fine. Yeah. You
Good
just make
evening,
it
everyone.
slide share.
Yes, sir.
Yeah.
Um,
Great.
Thank you. So, good evening, everyone. I'm Dr. Karishma, third year, final year PG from Ophthalmic Hospital. And today, for the session, my mentor is Prof. Dr. Chinmay JT. And I'm really thankful for this opportunity of learning. So, this is my patient who is a 56-year-old male patient who had come to our hospital with the chief complaints of swelling over the left eye, downward displacement of the eyeball, complaints of drooping of left upper eyelid since 3 years. And he also complained of diminution of vision from both eyes since 2 years. History of presenting illness. So the patient was apparently normal for 3 years ago, and he developed swelling in the left eye, which was insidious in onset, gradually progressive, and it was causing the downward displacement of the eyeball. And he also complained. He also gave a history of there is a superior limitation of the eye movements, but it is not associated with diplopia, suggesting us that there is no active nerve palsies for this patient. So, history of drooping of upper eyelid. It was non-progressive. It was not associated with limitation of movements, so rules out our third nerve palsy, and also not associated with deviation of the eye. And he also told there is no worsening of symptoms as the day progresses, and there is no difficulty in swallowing and climbing of stairs. Different again rules out a second differential, the myasthenia gravis. So history of diminution of vision in both eyes. It was in both eyes, and it was from 2 years. It was insidious onset, gradually progressive, and was painless and associated with glare. Coming to the negative history, so there was no any history of redness, discharge, and pain, telling that there is no active infection. Redness to rule out active inflammation also. So the main cause for the proptosis, the thyroid ophthalmic disease, active stage, it's not there. Second, there is no history of any ocular trauma or surgery, telling that there is no traumatic retrobulbar hemorrhage which is causing the proptosis. There is no history of heat intolerance, tremors, and palpitation, which are again is towards the symptoms of thyroid eye disease, which is not there in this patient. There is no history of fever, nausea, headache, and neck stiffness, which are usually seen in cases of cavernous sinus thrombosis causing a proptosis, which is negative in this patient. And there is no history of any head trauma or pulsatile sensation of the eye, which is most common seen in carotid cavernous sinus fistula. We can rule out this differential diagnosis also through the history. And there is no history of any weight loss or loss of appetite, ruling out malignancies. Past history. So this patient is a known case of diabetes mellitus since 15 years, and he is on tablet glimepiride 2 mg OD and tab metformin 500 mg BD, and his sugars are well controlled. Even he is a known case of hypertensive since 4 years, and he is on tablet telmisartan 40 mg OD, and even his BP is well maintained. He is not any known case of thyroid disorders, asthma, tuberculosis, or any other systemic malignancies. So there is no any significant family history in this patient. Personal history, he consumes mixed diet, has a good appetite, adequate sleep, and his bowel and bladder habits are regular. So coming to the summary, so my patient is a 56-year-old male patient with a swelling in the left eye, which is causing downward displacement of the eyeball with the ptosis of gradual onset and progression, with history of diminution of vision in the both eye. So my history is suggesting that it is a non-infective, non-inflammatory, could be a neoplastic lesion of benign etiology. General examination.
One second.
Wait.
Yes,
I think we can have a little bit of discussion about the history.
Yes, sir.
You mentioned that there is no diplopia, that is why you are ruling out a nerve palsy.
Yes, sir.
Can you have diplopia in the absence of nerve palsy if there is some involvement
Yes, sir.
of the orbital
Yes, sir.
dentates?
Diplopia can happen even in myasthenia gravis and also the thyroid orbital disease, sir.
Yes.
So these two, again, if it is a thyroid orbital disease, it would present with other histories also, like active chemosis. At least if not now is an active phase, at least 1 or 2 years ago, he would have had a active thyroid eye disease suggesting chemosis or anything. And if it is myasthenia, he would have told the classical symptoms of myasthenia, like drooping and climbing stairs, he has a difficulty or difficulty in swallowing, and the progression of worsening symptoms over the day. So these
In
things also.
thyroid eye disease, for the patient to develop diplopia, does it occur early or in the later stages?
Usually in the later stages, sir. Inferior rectus muscle is the most common one which involves, and it causes the diplopia. So
Because the patient
fibrosis of.
has to develop the after effects of thyroid eye disease, like contracture, fibrosis, the muscle. There
Yes.
should be restriction before
Yes.
they develop diplopia. Your patient, the history is almost 3 years now.
Yes, sir. So,
Okay.
yes.
But you are ruling out thyroid eye disease because of various other factors that you mentioned. There is
Yes.
no waxing and waning.
Dr. Karishma,
Yes, ma'am.
movement diplopia can be because of movement restriction also. It may not
Yes.
be because of nerve palsy itself. I think
Yes, ma'am.
I was trying to put that point across to you.
Yes, ma'am. Yes, ma'am.
Okay.
And any
Yes, madam,
history
please carry on.
being
Yes.
painless, painful progression, I think you can add that point to the presentation.
Yes, ma'am. He had a painless progression, ma'am.
Yeah, I know it's a chronic swelling, so usually I also looks very quiet, so it will be painless. Just mention it when you're presenting.
Yes, ma'am.
Dr. Karishma. Hello.
Ma'am, ಹೇಳಿ ma'am, there is some echo in your ಇದು ma'am. Kavita ma'am.
Kavita madam, you are on mute, madam.
What are the B symptoms, Karishma?
B symptoms. I didn't get.
If you're suspecting any systemic involvement in this patient. I think you mentioned about fever.
Yes, ma'am. I spoke about like active, like fever or headache or nausea, which are usually associated with infective signs, ma'am, like orbital cellulitis or any cavernous sinus thrombosis. They would usually have fever or any active infection present in the body.
And throughout the history, Dr. Karishma,
Yes, sir.
did the patient not complain of any problem with the ocular surface, tear film, lacrimation?
He actually didn't complain about lacrimation as
Whether it is hyper or hypo, patient
yes.
did not complain.
Yes, sir. He did.
Did you ask for that? Did you ask for with leading questions?
Actually, I missed out asking the question, sir.
Is it relevant? Is it relevant?
Yes, sir. It is relevant in lacrimal gland tumors. We would know if there is an hyposecretion and
No, we
causing.
have not come to a diagnosis yet at the history level. Yes. And did you ask any direct questions or indirect questions in relation to collagen vascular diseases?
No, sir.
Is it relevant?
Yes, sir.
Okay. Anyway, it's a your case with the history-wise, it's a chronic problem without much of an inflammatory component. That's where it stands now. Okay.
Yes.
Okay.
In the summary also, I think you can add it as a chronic presentation.
Yes.
Now, in the history, when you take the history in orbital conditions, how do you, what are the parameters to say it is acute? What are the parameters to say it is subacute? And what are the parameters to say it is chronic?
Sir, usually pain they will come, sir. In acute,
No.
acute present.
Acute. Duration wise, not the pain. Duration wise, whatever the presentation is there, depending
sir.
on the duration, you can classify.
Yes, sir. Like acute usually because of any trauma causing hematomas or anything, sir.
Duration, number of hours or days.
Yeah. Hours,
yes.
days, months, like that.
Sure about it, sir.
Usually, what happens is when it is in hours and days, it is taken as acute. When it is in days and weeks, it is subacute. When it is more than weeks and months, it is chronic. Especially orbital lesion. That's how they group it. Okay.
Yes.
So yours is definitely a chronic problem. 3 years now. 3
Yes,
years now. Okay.
So what are the differential diagnosis do you think at this level for a unilateral slow progressing proptosis?
So I am thinking of a benign orbital tumors which could cause this, like a schwannoma or a pleomorphic adenoma, which also has a slow progression. Because it is an inferior displacement of the eyeball, these two are my primary things, ma'am. Again, some patients of frontal mucocele also would have a downward displacement.
Frontal mucocele, is it direct downwards or?
No, sir.
Yours is straight downwards, no?
Yes, sir.
Okay.
So how it is in frontal mucosal?
I just wrote if it down.
Frontal mucosal would have pushed it down and out, no?
Yes, sir.
Yes. Okay. Anyway.
So did the patient complain of diminution of vision after harm?
Ma'am, we can't hear you, ma'am.
Yeah, okay. Does the patient complain of diminution of vision?
Yes, sir. He had a diminution of vision, sir. Okay. But it was not a sudden onset or anything. It was gradual and it was progressive, sir. Examination reveals more details.
He put it as, I think, dimness of vision in both eyes.
Yes, ma'am. He told that there is a diminution of vision in the both eyes, but in the left eye more than the right eye. He had
when there is a diminution of vision in the presence of an orbital lesion,
yes, sir.
What do you suspect at the history level?
Sir, any at the history level, if first I would ask if it is a sudden onset or like acute onset diminution of vision, sir, to rule out if there is an orbital apex involvement of the lesion that is caused.
Is it sudden in onset? Orbital apex syndrome?
No, sir. I mean, like.
Yes. Go slow. No problem. You take your time. Now, the thing is, you think structure-wise. Okay. If there is diminution of vision, which structure is probably involved along with the orbital soft tissues? Which structure subserves vision then?
Sir, in this patient, I was more thinking towards the lesions only, sir. Otherwise, the common causes would always be because...
No. This is a general question. This is because you mentioned diminution of vision along with an orbital lesion. You have to connect the two.
Yes, sir.
Okay. Anyway, it suggests that optic nerve may be getting compromised. The lesion may be hitting on the optic nerve. Maybe not in your case, but that's how the thinking goes. That is the line of thinking. Okay. Continue.
Yes.
Shall we go beyond history now?
Yes, sir, we can go.
Yes.
So on general examination, the patient is conscious, cooperative, well-oriented to time, place, and person. He was moderately built and nourished. There was no pallor, icterus, cyanosis, clubbing, and any lymphadenopathy or edema. The pulse rate, BP, and respiratory rate were normal. Even the systemic examination was normal. On ocular examination, the head posture was...
Wait. 1 second. Lymphadenopathy. Which lymph nodes, which group of lymph node did you check?
So we would check the lymph nodes, especially the preauricular lymph nodes and the submandibular lymph nodes. Sir, if there is any malignant lesion, there would be a chance of lymph nodal infiltration. So we have to check the submandibular and preauricular lymph nodes.
Yes.
Any other lymph nodes you want to check apart from these two?
Not sure.
Okay.
So coming to the ocular examination, the head posture was normal. The facial symmetry was well maintained. Ocular posture, there was an inferior dystopia.
Can you give me a definition of dystopia?
Sir, whenever there is a displacement of an eyeball in such, then we'll call it as a dysplasia. Like when we are doing a Hirschberg test, it is at the center of the pupil in the both eyes, suggesting that the visual axis is normal, but there is an inferior displacement. Then we will call it as dystopia, sir.
Dystopia, is it only inferior?
No, sir. Like dystopia can be superior and inferior.
Displacement of the eyeball in the coronal plane.
Yes, sir.
Okay, continue.
Dystopia in the x-axis or y-axis, not in the z-axis.
Okay.
Z-axis is usually anteroposterior. No, dystopia is either horizontally or vertically.
Okay.
Continue.
So
how do you record for the dystopia? How do you measure for the dystopia?
Ma'am?
How do you measure dystopia?
How do you look for the, how do you record, how do you measure dystopia?
Ma'am, we can actually use the bedside, we can actually use this two ruler method, ma'am, where we put two scales and different Moni margins and measure the amount of the displacement that is there.
Correct, yeah.
Continue.
So on the assessment of visual function, distant vision in the right eye was 618 parts and left eye was hand movement positive. The right eye vision with the pinhole was improving to 6.9 and the near vision was N12. The color vision, contrast sensitivity and brightness sensitivity was normal. Even the confrontation in the right eye was normal. Whereas in the left eye, it was hand movement positive. So the rest of the test couldn't be assessed because of the poor vision. Coming to the refraction, it was done under tropicamide at 2/3 meter. It was plus 0.5 vertical and horizontal meridian. And the BCVA with minus 1.25 spherical, it was improving to 6.6. Whereas in the left eye, there was no glow. So the BCVA was also hand movement positive. So the coming to the main topic for the today, which is proptosis evaluation. So whenever a patient comes with a proptosis, I would like to evaluate in the 4 headings. First is inspection, then is palpation, then the auscultation and the measurements of the displacement. So coming to inspection, we can see that there is a periorbital fullness over the left eye and there is inferior eyeball displacement in the left eye. And we can see that there is some kind of swelling, an orbital swelling or the mass present with this, which is, we can see that over the eyelid, it's a smooth surface. And the swelling, so whenever the patients come with the proptosis, one more test we will do is swelling, to check the swelling in the bending forward position, all the Valserva maneuver, which becomes very important in the cases of orbital varices, where the patient's eye might look normal or enophthalmos in some conditions. There were no visible pulsations to, like usually this pulsating proptosis was seen in carotid cavernous fistula, and the skin over the eyelid also was appearing normal. Coming to palpation, so all my inspectory findings were confirmed. Finger insinuation test. So the fingers couldn't be insinuated between the globe and the orbital rim of the superior region of the left eye, suggesting that there is an obvious orbital swelling or a mass. So on palpation, I could see that it was around 2 to 2.5 mm round swelling located in the supraorbital region, and it had a smooth surface. It was firm in consistency and it was fixed. There was no tenderness or local rise of temperature, ruling out the infection. Orbital margins were regular and continuous, suggesting that it was a non-malignant lesion. On the retropulsion test, when I have put my fingers on the lesion, there was, on the eyeball, there was no resistance felt, suggesting that there is no lesion behind the eyeball. There was no infraorbital and supraorbital anesthesia, which becomes an important thing during the trauma cases. There was no enlargement of the regional lymph nodes.
Can I
On
get
Oscar,
just one question here?
yes, sir.
Can you tell me the difference between compressibility of the lesion and reducibility of the lesion?
Yes, sir. When we press on a mass and it goes back, then we call it as a reducibility. When we press on a lesion, it goes back and come back to the position after releasing the hand or releasing the fingers. Then it is compressibility. Compressibility we usually see in vascular tumors.
Comes back immediately once
Yeah,
you
comes back
remove
immediately.
what happens in the other reducibility if the mass is reducible?
Usually, reducibility is rarely seen in orbital.
Is it?
I'm not sure.
On removing the hand, if the
It
lesion
will
or
stay back.
mass takes some time, or
Mm.
you want the patient to have a Valsalva maneuver, then it comes back, isn't it?
Yes. Yes.
Okay. You know any lesion which presents like that? In the orbit only.
You
Schwannomas sometimes have a reducibility. Sir.
Which one?
Schwannomas sometimes have reducibility. Sir.
No, see, for reducibility, what is the prerequisite?
It should.
The mass has to go into some other compartment,
Yes.
isn't it? For compressibility, the mass is vascular, so it can reduce in size the moment you put pressure. Whereas
Yes.
if the mass is reducible, it has to go into some other compartment and it will come back to the original compartment only on Valsalva's maneuver. So which mass can come back? Yes.
Orbital varices, sir.
Yes.
Varices, yes. Varices, you can even have in ophthalmos on presentation, but on Valsalva, it does come back. Any other lesion? Suppose you have a defect in the roof of the orbit for some reason, surgical, neurofibromatosis.
Some neural tissue.
You have a pulsatile proptosis also.
Yes, sir. CCF, sir. Carrot. Sphenoid neurofibromatosis sometimes have a pulsatile proptosis and
No, neurofibromatosis per se will not have pulsatile proptosis. It is because it causes a defect sometimes in the roof of the orbit. So, roof of the orbit, what gets transmitted to the orbital contents?
Yes, sir.
What are the types of pulsations you see in the pulsatile proptosis?
True pulsations and transmitted pulsations, ma'am.
Yeah.
True pulsations are usually seen if it is an arteriovenous connection or a like veno-lymphatic or arteriovenous connections. And if in a transmitted pulsations, it is because of the CSF. Whenever there is loss of bone where CSF can be visible, like loss of roof or loss of frontal bone, we can see the CSF pulsations.
When there is loss of lesser wing of sphenoid in case of neurofibromatosis.
Neurofibromatosis also, we see a pulsate.
Karishma, is it a pulsatile proptosis or what in the roof of sphenoid? You will have proptosis or inophthalmos. Classically, pulsatile inophthalmos is there in neurofibromatosis. But if you have a additional optic nerve glioma or something, then it may cause pulsatile proptosis also. Yeah.
Okay. Next, continue.
So on auscultation, no bruit was heard. So coming to the measurements, so the palpebral aperture we have measured with scale was vertical palpebral aperture was 10 mm in the right eye, whereas in the left it was 7 mm, suggesting that there was a
finish off one eye at a time, then you can go to the other eye.
Okay, ma'am. So the axial measurement for the displacement of the eyeball was measured from the lateral orbital margin to the corneal apex with a Hertel's exophthalmometer. It was 17 mm, and in the horizontal from the middle of the nose to the nasal limbus, it was 21 mm, and in the vertical from the superior orbital margin to the inferior limbus, it was 20 mm. Whereas in the left eye, it was axial was 20 mm, suggesting that there is a 3 mm axial displacement and in the horizontal it was 25 mm, suggesting that there is a 4 mm lateral displacement of the eyeball, and in the vertically there was a 30 mm inferior displacement of the eyeball. So this is our Hertel's exophthalmometer that we have used for measuring the axial displacement. So
Vertically, you
whenever,
mean 30 mm? 30 or 13?
sir, it was 30, sir.
30.
Yes,
30
sir.
mm. What is the height of the orbital cavity?
Its height is 40 mm, sir. The width is 35 mm, sir.
Hmm.
Yes, sir.
Okay, continue.
So
Because
this, yes, sir.
for that much of displacement, the 30 millimeter downward displacement.
10
It's-
mm downward displacement she has
10
mentioned.
mm downward displacement, sir.
10 mm, no? Okay.
Yes.
10 is okay. Okay.
Yes. So this was our Hertel's exophthalmometer that we have used for measuring the axial measurement. So whenever
When
we are
you are
measuring,
still on exophthalmometer, what
sir,
are the different types of the exophthalmometry that you do? Not the exophthalmometers, exophthalmometry types.
exophthalmometry, like one, I know the types, sir. Like the
Now you said that the left eye, what is the proptosis measurement?
left eye, it was 3 mm, sir, axially.
It is 20.
Like
That's what you said.
20, sir.
20. Okay. So what is it called? When there is a measurement of one eye beyond
Yes.
the normal range, what is it called?
Proptosis, sir. So
Proptosis of
whenever
the exophthalmometry is called
ax-
absolute. It is
yes,
absolute value.
yes, sir.
Now you compare with the other eye. What is it called?
Asymmetry of greater than 2 mm we call axial proptosis.
That's right. Exophthalmometry values, the difference between the two eyes is called in relation to the other eye.
Asymmetry.
Just use the word relation.
Asymmetry, sir.
Relative exophthalmometry.
Relative X. Okay, sir.
And you see the same patient over a period of time. Every time you measure the proptosis, that is called comparative exophthalmometry. Whatever exophthalmometer you use, these are the clinical terminologies that you should be familiar with. Okay, continue.
Any other ophthalmometers, exophthalmometers?
Yes, ma'am. I know the Lutz exophthalmometer and the Nagel's exophthalmometer, ma'am. So whenever, usually the main disadvantage of the Hertel's exophthalmometer is that whenever there is a trauma patient and there is a lateral orbital margin involvement, so we wouldn't be exactly measuring the displacement. So in that kind of cases, the Lutz, which is like a plain ruler, will help us to measure the which will help us to measure the displacement. And also in the needles, the main support is superior and inferior, so there also we will be able to measure
Ludes also we keep on lateral orbital rim only.
Yes, ma'am. But
what about the transparent scale?
Transparent scale, like on a regular basis we would be using a transparent scale, so two vertical scales, two ruler method we use to measure.
What is the problem with parallax? Have you heard about parallax?
Yes, sir. So the Hertex, I don't know how to explain it, sir, but whenever a person,
the markings
on the exophthalmometer, the front part will have like 100, 90 and 80 centimeters. One person, if we are seeing at 90 centimeters, the other person is seeing at 80 centimeters, there will be a different of values when we are measuring. So whenever each person change, also the number in the front when we are checking should be same, sir.
Repeatable. Okay.
Repeatable.
That is called as base value. So first person who records the value should set the base value, so that every time when you record it, the other person, whoever is doing, should keep it at the same base value. That is what it means, but it is not parallax, what you're telling.
Yes.
Parallax is got to do with the markings.
Yes, sir. There is a red line that we have to align for the
corneal apex.
Still, there are chances of parallax in Hertel's. Any other, which is more accurate? Something which starts with M.
Mauritius. Some Mauritius
Moritz, it's called as Moritz.
Moritz.
Any other way of doing exophthalmometry?
CT, ma'am. CT, we have to measure from the interzygomatic line to the lens, the distance. It shouldn't be more than 21. If it is more than 21,
So you don't have access to radio imaging in any other way you can document it if you don't have any tools.
Scale.
This is also photo. You can take pictures and then do the measurements. So digital exophthalmometry, that's the word for it. That's the other way of monitoring.
How do you grade your proptosis depending upon your exophthalmometry readings?
Grading. Mild, moderate, and severe, ma'am. If it is greater than 2, like if it is 2, it is mild. 2 to 4 is moderate, and greater than 4 is severe.
Severe, yes.
Could you do the Navziger's method in this case?
Sir, actually, we missed doing the Navziger's and Worms view. So, like we didn't take the photos of
That's very important.
View.
You did it?
We saw it, sir, but we didn't take photos.
No, the thing is, it's getting complicated because of the ptosis. You have a ptosis there.
Yes, sir.
Yes.
Yes.
But still,
once you look at the eye like that, because of the ptosis, the proptosis is not becoming prominent.
Yes.
Inspection wise. So the Navziger's and Worms view is important.
The Navziger's and Worms is particularly very important in the mild ptosis. We can't because that is the only way we can pick up a very mild proptosis. So it's important to mention in the case sheet. For exams, you have to mention
you
that.
Have to mention, yes.
Yes.
Continue.
So these were the photos where we had done the Hertel's exophthalmometry. And coming to the, sorry, so there is little. Coming to the lids, right eye was normal, left eye there was a ptosis. Conjunctival, bulbar, palpebral, and fornical conjunctiva was normal. Sclera was also normal. Cornea, size, shape, surface, sheen, and sensations were also normal. And transparency.
Hold on. Conjunctiva is normal?
Yes, sir.
Is it? Okay. Now, in this one, the slide, I thought you have mentioned there is a lesion on the eye itself.
Yes, sir.
Where is it present?
Like it is in the orbital region, sir.
Oh, it is beyond the palpebral aperture.
You should mention palpebral conjunctiva also.
Yes, ma'am. It is behind it. So.
Okay. Continue. No, I thought there is some lesion because in some of these orbital lesions you can have a conjunctival lesion also, subconjunctival, episcleral lesions also. Okay, continue.
So the AC depth was normal, and contents there was no cells in flare. Iris was also normal. Pupil, the size, shape, position, it was 3 mm round central. The direct and consensual.
What should you look for in the iris?
Iris color, and if it is like lesions like neurofibromatosis, we can see the leash nodules.
Yes. Leash nodules you should look at.
Yes. In lens, the position was normal. There was a greenish central reflex, like suggesting that there is a cataract, and even the whitish reflex in the left eye, suggesting that there is a mature cataract. Shape was normal. IOP measured with Perkins applanation tonometry at 10 a.m. on 15/11/2025. It was 15 mm Hg in right eye, and left eye it was 16 mm. Extraocular movements.
1 second. IOP. Yes. Did you try to see the IOP in a different gaze?
So actually, I didn't see, sir, but we should see, especially in cases of thyroids, it would have been raised.
Yeah, not only thyroid, even in other orbital lesions where you
yes.
suspect a restriction, it can have
Yes.
an effect on the intraocular pressure. Yes,
Yes.
continue.
Yes.
What is the sign called where there is change in the IOP values? Do you have any idea?
Wiesel sign, ma'am.
Braille sign.
Brace.
Braille.
Braille.
B-R-E-Y.
Okay. So
what should be the difference?
Ma'am?
If how much difference is there in the IOP measurement, you will take it as I mean, what do you differentiate with this IOP measurement?
Like we have to compare with the normal eye and the other eyes. I'm not sure.
No, it's in the primary
different gazes if you check.
Gazes, yes. Primary gaze and the superior gaze usually.
How much difference is significant?
And why should you do that? What inference can you draw from that if there is a raised in IOP in various in different gazes?
What is yes?
Any muscle restriction which is causing the effect on IOP.
Yes, fibrosis restriction mainly because of restrictive ophthalmo reduction, restriction of the movements because of fibrosis. It could happen even in thyroid ophthalmopathy also.
Yes.
So it need not be only in superior gaze. It should be in the direction of the movement of restriction.
Yes, ma'am.
Okay, so if the difference is more than 6 mm Hg, it is due to restriction, and if it's less than 6 mm Hg, it will be more of a neurological condition.
Okay.
The restriction. Okay, I mean the movement, less movement on that side.
Okay.
Okay, go ahead.
So on extraocular movements, the ductions and versions were full range in the right eye, whereas in the left eye, yes,
you have mentioned that the pupil, the lens has cataract, right? So,
yes.
So what is the visual potential of this patient from your examination as of now?
Actually, the right eye had a lesser grade of cataract, ma'am. Left eye, it was an SMC.
So it's a mature
we couldn't exactly tell about the visual potential of this patient. One that we had, like in this stage, we don't know the radiological investigation telling that there is any compression on the optic nerve, and because it's an SMC.
The pupil reaction is normal now.
Yes.
That itself is an indication, right?
It's a brisk
pupil reaction is normal.
Yeah. That is the thing, yes. Okay. Yeah, go ahead, please.
So you are mentioning that the extraocular movements in the left eye are normal, isn't it?
The extraocular movements in the left, there was a superior limitation, sir. It felt more of a mechanical limitation because of the huge swellings, sir.
How do you know it
How
is
do you
mechanical?
account for?
Ma'am?
No, I answer the sir's question. No.
How do you say it is mechanical and it is not neurological, the restriction?
Sir,
limitation
usually
of movement. I cannot say.
Limitation of movements, if it is neurological, the initiation of movement, the saccades won't be there if it is.
No, do you have any test to differentiate limitation of
Force
extraocular?
duction test. Force duction and force generation tests will help us to rule out, sir.
Yeah, may not be very relevant here, but still you should know it. Yes.
How do you account for the presence of ptosis here? What could be the reason?
Ma'am, I felt the ptosis here was because of the swelling only as such, but not it was not correlating with any other like causes for the ptosis, ma'am.
So again, you think it's a mechanical ptosis?
Yes, ma'am.
Are you ruling out involvement of the LPS superior rectus complex?
Sir, the levator function was good for this patient. So we had evaluated, but I had not put it. But we had evaluated ptosis also. The LPS function was
function
good.
Is good. Great. Yes, that is how you explain it. Yes.
So
Okay,
then
fine.
the ptosis goes because of the swelling there, mechanical ptosis.
Yes, ma'am.
Okay, continue.
So on fundus examination, the right eye, there was on distant direct ophthalmoscopy, the red glow was seen. In direct ophthalmoscopy, at near, it was only disc was appearing normal.
Right eye, is it
You can
essentially
say
normal
normal.
fundus?
No, sir.
Is
So
it
normal
essentially
fundus
normal
means you can
fundus
just
in
say
the right
normal.
eye?
Right eye, it is a normal fundus, ma'am. Left eye, because it is an SMC, we couldn't
Hold
see
on,
it.
hold on. In the left eye, suppose if the fundus were to be seen,
Yes,
if
sir.
there is no mature cataract, it was an immature
Yes.
cataract, what are the findings do you expect in the fundus in the left eye?
Yes, sir. I would see for the choroidal fold, sir, because it is such a huge lesion compressing on the eyeball. We would look for the choroidal folds first.
Yes, great.
And
Yes.
any optic nerve, because the pupil reflex is normal, it wouldn't be
What do
involved.
you look
But
for
if
in the
there is
optic nerve? Optic disc?
papilla edema or
Edema, yes. Disc edema, yes, fine.
disc edema, or because it's 3 years, it could have been atrophy also would have been there, but it would correlate with the pupil.
Anything else on the disc itself?
Some vessel
Any
abnormal.
like metastatic lesions would have any intra
No, vascular lesions. Any vascular findings on the disc itself, within the disc margin?
this shunts, sir.
What shunts? Correct.
Optociliary shunts.
Optociliary shunts, you have to, because we are not yet arrived at a diagnosis. It's still a mass in the orbit.
Yes.
So these are the things to be expected. I'm not saying it will be there. These are the things to be expected before you do a examination. Okay. Anyways, now that there's cataract, you can't see. Okay, let's go ahead.
Any mass with this optociliary shunt, chronicity, any mass you can think of?
Hemangioma. Venous lymphatic malformations.
No, optociliary shunt is a diagnostic of one particular tumor, no?
Yes, ma'am.
It is not pathognomonic, but it helps in the diagnosis. Meningioma.
Because you are in the anterior orbit, maybe.
Yes.
If you go in the muscle cone and think of some mass there, you'll get one.
Optic nerve gliomas or optic
Not
nerve.
glioma.
Optic nerve sheath meningioma.
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 Yes. Yes, continue.
Yes.
Dr. Soumya, can you hear me? Dr. Soumya?
Sir, yes, sir.
If we are exceeding the time, please warn us.
No.
You know, we are teachers, we go on like this.
No, till Karishma is answering all the questions beautifully, I guess we can
She is
continue
doing
on.
well, no problem.
She's doing well.
No, we also should have some control,
Yeah.
no?
No,
Over
I
us.
have the feeling. No. I have the feeling of a PG exam going on. Definitely in a real-time postgraduate. Yes. Please continue, sir.
Okay, thank you. Continue, Dr.
Yes.
Karishma.
So the summary from my ocular examination that it is first abaxial proptosis of the left eye, and it was secondary to a swelling which is of 25 into 25 size with a smooth surface, regular and firm consistency, and it was immobile and it was painless with smooth orbital margins. So it mostly goes towards left eye benign lesion in the supraorbital region of the orbit from the examination. So my primary differential diagnosis would be lymphoma, because the age of the patient was 56 years old, and at this patient the most common tumor in the intraorbital space is lymphoma, and the second most common tumors are hemangiomas. But here the hemangio and the third diagnosis which I had was supraorbital nerve schwannoma, and the fourth was pleomorphic adenoma of the lacrimal gland. Again, the pleomorphic adenoma would have caused a down and in proptosis rather than a down and out proptosis. So that one we can rule out. So the rest of the things we will rule out with our diagnosis.
Metastasis also, I think you should keep in mind.
Yes, ma'am. Okay.
I think metastasis will always be the first. See, morning also I told Karishma, metastasis is the anywhere in the body, that is the first. First
Yeah, that's a
metastasis, then primary
56-year-old.
tumor. Yes,
Yes.
yes. That is the
So
first
what do you
thing.
think? Yes. What do you think
Why
are
do
the
you think?
common cancers
Yes.
which causes metastasis in the orbit in a male and in a female?
Ma'am, in the females, breast carcinoma, they usually come with metastasis, ma'am. Even in the males, the prostate is a most common tumor that comes with metastasis, ma'am.
You said it
Can
is.
we have enophthalmos? Yes, sir.
You mentioned that it is benign. You think it is benign, isn't
So
it?
because
No. Wait. No,
yes,
my question is not that. My
yes,
question is, what are the points which favor a malignant lesion in the orbit?
sir.
I
One
think
is
the presentation is too long, 3 years.
yes,
Yes. One is it is a chronic presentation.
present.
Yes.
Usually, if it is a malignant lesion, he would have come more earlier, and there is a rapid progression of a lesion, is one thing, sir.
Mm.
Second, because I checked for the orbital rim margins, which were very smooth,
On
it
clinical
was not
examination, there is no evidence of bony destruction.
evidence of bony lesions. So that was one more
Bony
thing that I was thinking that
affection
it
of the
was
bone is not there. Okay.
Bony
Okay.
erosion.
The tumor,
bony.
sorry, not the tumor, the mass itself, is it extending beyond the midline? Suppose if you consider the lateral orbital margin and the medial orbital margin, the lesion,
Yes.
is it extending beyond the midline towards the medial side?
No, sir, it was not extending, sir. So
It is not extending.
yes,
Okay.
sir.
Okay. Now, how do you?
I think your mass was central, right?
Yeah, it
Yes,
was central.
central mass, ma'am. But the
Is it
posterior
central?
couldn't, like, it was exactly causing the down, so it could be central, sir. But in the proptosis examination as such, we could see that there is a horizontal
You
displacement.
palpated the mass, no? Where was it? Central
It
one,
was
lateral.
no, ma'am. It was in the central part only, ma'am, on palpation.
No. The idea of asking this question is to, just to have a feeling about the involvement of the lacrimal gland.
Yes.
Whether it is benign or malignant lacrimal mass.
Gland tumor mass. That is the question, because we have to be sure whether it is a standalone central mass in the superior orbital peripheral space, or is it a lacrimal gland lesion which is affecting the main lacrimal gland as well as the palpebral lobe. That was the idea of asking that question. Suppose if it is a benign lesion, usually it tends to get limited towards the lateral part, doesn't cross the midline. The moment it crosses the midline, you have to think of malignancy. That was the idea of asking that question. Anyways, continue. Now that you have come at arrived at a differential diagnosis, how do you proceed to get a proper diagnosis now? Correct diagnosis.
So we were going for the investigation, sir.
Yes.
So because we couldn't rule out exactly what it could be, a lymphoma or it could be a lacrimal gland tumor or it could be a schwannoma, so we wanted to differentiate. So we had first wanted to rule out the, so usually the patients come to us with the cost effects. So the primary thing we send is CT orbit and Bain, sir, because we want to completely rule out the malignancy first before going in detail about the lesion. Like when we already very sure about the diagnosis, like some diagnosis like optic nerve glioma, there is a proper axial proptosis, those we can send an MRI brain. So this patient, we were ruling out many, so we had sent a CT orbit and brain, sir. So
I think CT orbit is a very decent investigation to do, even if there is no cost constraint.
yes,
CT is the preferred investigative modality for orbital lesions. Okay.
yes,
If you are suspecting any infiltration or
mm.
soft tissue, how much involvement is there, then you go for MRI. Okay.
MRI.
So now I'll describe the CT findings.
Yes, sir. So this is my CT, sir. It is a CT film taken in the mid-orbit plane, and it is a coronal section. We can see that the eyeball of the when comparing to the right eyeball, the left eye is smaller, telling that there is a proptosis and it is finishing faster. And we can see a round, smooth, homogeneous mass over the eyeball, and which is causing the convexity of the superior roof, telling that it is a chronic change. So Based on only this, we can't exactly tell it is a lymphoma or a
What is
squamous.
the change in the bone called?
Ma'am?
Where it is accommodating the mass, no?
Yes, ma'am.
So what's this change in the bone called?
I don't know.
It's called as fossa formation.
Fossa formation. And also, it is the lesion is almost conforming to the surrounding structures.
Yes.
Okay. Okay. Continue.
So my next film is a sagittal section. We can see that it is covering the whole of the eyeball, and this is one more section where we can see the extent of the lesion where it is very huge and homogeneous. So this is a series of the like planes where we can see the extent of the lesion, especially during the surgical procedures when we want to know the extent of the lesion, like to tell the like the prognosis of the post-op of this patient. We would know the like, and to know the exact location of the lesion, we would like to see the series of progression. This is also a lesion, so it is extending till almost the completion of the eyeball or towards the apex. So what we had done was like Chinmay ma'am had done this procedure. It was we had done a left eye anterior transconjunctival orbitotomy with a vertical lid split to access the lesion, and this is our intraop photo where we can see a huge mass with connected nerve ends. Mass with the connected nerve ends. We were on table. We were confirmed to our diagnosis that it was a schwannoma. So we had sent for a HP correlation, sir, and on histopathology.
Which nerve is the one which causes this? Like which particular nerve?
From where it is.
Yeah.
So it was the supraorbital nerve branches which were causing this schwannoma, sir.
Okay, supraorbital nerve. Okay.
Can you please show the rootlets, because for this particular patient there were three rootlets of the nerve.
Yes.
Can you just zoom for the benefit of other postgraduates, if you can zoom?
1 minute, ma'am. I'll just...
Okay. Escape.
Yeah,
Press
yes.
escape. Go present from current slide.
Yes.
Yeah. Current slide you put. Slideshow current slide. View.
Yes, ma'am.
Current slide. Yeah. If you zoom, you can see the thing.
Not it.
No, it is seen. Yeah. Okay. Just put current slide. We can see the rootlets.
You can see the rootlets now also. Now we can see.
Yeah.
Yeah.
So
you can clearly see it. It has come out en masse, so nicely dissected.
Very well operated.
Very well dissected.
So
probably one of the reasons for pain maybe is because of the affection of the nerves, rather than any inflammatory component there. Yes. Okay.
So
now you mentioned that it's in the hello.
Hello, sir. Gross wise, even the lymphoma consistency is also very similar, but because of the rootlets, it was coming to schwannoma.
Yes, ma'am. Yes, madam. Now she mentioned that in the CT it is extending up to the orbital apex. Whenever a lesion appears to go towards the orbital apex, any other investigate imaging studies you would like to do?
MRI.
MRI, yes. Whenever you are going towards the apex and the soft tissues, you have to go for MRI. Not in this case, but that is the one of the guidelines.
Yes.
Okay. Continue.
Yes.
The CT looks very tricky in this case. The mass, I think it looks like a lacrimal mass.
Yes.
It was very close to the lacrimal gland as such, ma'am, in the series of the films. So we were.
But in spite of the mass effect, there is no tear film affection there. Did you do a Schirmer? Schirmer was normal.
I had not considered.
Okay. See, any orbital mass, particularly near the lacrimal gland, Schirmer is a must.
Yes, sir.
Anyways.
Any name for this vertical lid split technique?
Lynch. No, ma'am, it is. I'm not. Lynch is the similar one which we do medially, ma'am.
Yeah. Okay.
I'm not getting the name.
So this is almost an excision biopsy.
It's called as biopsy.
What is the role of an incisional biopsy?
So whenever we are like when the diagnosis is more towards the malignancies, it is safer to do an incisional biopsy. Be sure about the lesion, because one thing when we are doing, there are chances of spillage to the extraocular contents. So it is safer to do an incisional biopsy when
which orbital this one mass you should not do incisional biopsy and breach the capsule. Any orbital mass where it is not it is not advisable to breach the capsule by doing a biopsy, incisional biopsy. When you are sure about it.
Lymphomas.
Not lymphomas.
See the CT if you had left part of this back.
You think beyond this?
Yeah, some clue I gave in the CT.
Adenocystic carcinoma of lacrimal gland.
Carcinoma.
Carcinoma.
Which again lacrimal gland mass only. Which mass it is better not to breach the capsule, so that otherwise you will leave lot of seedlings and a recurrence can happen. It's a benign lesion.
Recurrent and it can turn to malignant.
Adenoma. Pleomorphic adenoma.
Pleomorphic adenoma, isn't it?
Yes.
Okay. In an adult like this, particularly a female, if there is an axial proptosis,
yes,
and there is a retrobulbar mass, what is the most, and a female patient, what is the most likely to mass? What is the most likely?
Pleomorphic adenoma, sir. Female.
Retrobulbar. I'm saying muscle cone, retrobulbar.
Retrobulbar with the female.
In a female, middle-aged female, causing axial proptosis, what is the most common neoplasia or mass?
You saw something in the fundus also.
Optic nerve sheath meningioma.
No. Optic nerve sheath meningioma will have many more findings. And it may cause an eccentric proptosis. Whereas a middle-aged 50-year-old female coming with axial proptosis, and that too, the mass is very nicely removable, usually well encapsulated.
Yeah, one of the
venolymphatic malformations, sir.
Okay.
No. Some vascular malformation only, not venolymphatic.
Commonest, Karishma. What is the commonest thing?
Hemangioma.
Which hemangioma? Capillary, cavernous?
Cavernous.
Yes, good. Okay.
If this patient had good vision, okay, what prior investigation you would have done before removing this mass? It's causing proptosis. No? Any prior investigation you wanted to do related to the eye? Because of the
How to routinely we do know for all the patients at the orbital apex.
Related to the eye, MRI we will see.
In our department only, what do we do?
The patient has but subnormal vision. And it's very important for us. Post surgery also we have to tell them why the vision is, before the surgery is subnormal and it can persist even after surgery.
Serial follow-up we can do with that, no? Women's patients and all, yesterday's patients. Is it so difficult?
No, ma'am.
Yes.
Okay.
So actually many a times when you are dealing with an orbital mass, when you are worried about the optic nerve. You have to do a continuous monitoring of the VAP in consultation with VEP in consultation with a neurosurgeon, isn't
Yes.
it? Mm.
Visual field is very important for you and for the patient also.
Yes, ma'am.
Okay, Dr. Soumya, where are we?
I think that
Karishma has finished her presentation, I
histopath
guess.
slide once.
Ma'am?
Histopath. You can
Yes.
discuss
Yes.
quickly.
So on histopathology, we can
Please
see
take
the
the current view, no? We can't see detail. No, that
yes,
histopath.
ma'am. I'll
Put
put.
slideshow. No. Yeah, zoom.
So we can see in this part, there is a slender spindle cells in palisading pattern, suggesting that is an Antony A type of picture. And in this part of the picture, we can see that these spindle cells are dispersely arranged with an Antony B type of a pattern, suggesting that it is a schwannoma in the HP image.
it is one of the important questions asked. The antibodies.
Yes, ma'am.
Can I ask you one more last question?
Yes, sir.
Histopathology. What is
Yes,
the histopathological finding in case of meningiomas? Somebody?
Baroque bodies.
No, you have to sum it up. Did you get the clue?
Gave a clue.
Someone body.
Someone's body?
Samoma bodies. Samoma body.
Someone's body. Okay, good. Okay. Very good presentation. Dr.
Well
Karishma.
presented.
Well presented, yeah.
And case is very well managed. Congratulations to Dr. Chinmay.
Yeah.
Thank you, sir. Very good discussion, sir. Lot of questions from the past. Many PGs are not used to the old questions, which are really good inputs from all of you people. So it was really good.
Thank
I
you,
think
sir.
they would have known different exophthalmometers, but not
Yes.
thermometry.
Correct. Yes.
Swastika, do we have any questions in the chat box from that end?
No, I don't think there are any.
I don't think. I think first of all, my initial comments now is I was really feeling that a real-time postgraduate exam was going on, and I really feel that Karishma now would be very, very confident enough to present a case of proptosis, I guess, in the exam. So she's very well prepared, and this just went on. What an inaugural session of our academy we had. Such a very good, such a good discussion, starting from the basics till the management. Now, I would just want all of you to just have all of you to just give small comments on this, and I would first ask Karishma to just comment how she felt about this entire, 1 hour.
Actually, it was very much informative, ma'am, for us. Like we could think through the diagnosis. We could actually think through the diagnosis very well, like where it plays an important role for the smaller tests to the bigger tests, how we have to diagnose a thing. It was very much learning for me and for the other PGs, ma'am.
Yeah, definitely. Thank you so much. And now I would ask Chinmay before she goes off to Himalayas. Chinmay, what is your take on this? Like, really well prepared, and you have prepared Karishma to this. And every message, whatever I put, she had promptly responded. I don't think she's just gone off to the Himalayas now. Chinmay?
Yeah. Thank you so much for taking the initiative to form this Karnataka Association. And it's a very good platform for postgraduates to have our different faculties. Particularly Mysore is like from my PG days, I know it's like very good teaching happening there. And Kavita ma'am from Hassan University.
Hello? I think she lost her network probably.
Hello.
Yeah. Um, Bindu, can you just give some comments on this by the
This
time
was a
Chinmay comes
visit to
back?
my post-graduation days. I think all my teachers are here, and I think this is the first time I've taken an examination for a postgraduate, that too on an online platform. But it was a great learning process for the students as well as for the teachers, I feel. Thank you, Mahesh sir and Soumya ma'am, for this opportunity and a great initiative. I hope it keeps continuing.
Thank you, Bindu. Prakash sir.
So, thank you, the organizers, Dr. Soumya and Dr. Mahesh, for giving me this opportunity to be with you. This is a wonderful, beginning. This is a wonderful beginning. So, we touched upon the basics actually. It's so advanced nowadays that it goes. Actually, we didn't touch upon some of the recent advances because it goes beyond the limits. Anyways, this is what the postgraduates need. Then you should develop the art of presentation. The idea is to make them feel free, develop the confidence, and put the subject. They'll be knowing the subject. Sometimes they'll not, they'll be so tensed up, or the order of presentation will go awry. So if it is for them to present as they present in an examination, this will give them the confidence for further presentations in conferences and other places. So I thank you all for this opportunity to be part
Thank you
of
so
this
much, sir.
initiative. Thank you.
Thank you so much, sir. Kavita madam.
It was a very good initiative. I thank Dr. Soumya and Dr. Mahesh for taking this. Lot of effort has gone into for us to see this day in this session. And actually, getting a uniformity in the PG teaching is very, very important these days. And at least, as we said, today it is a day of competency-based education. That means at least one standard of education all the postgraduates have to attain. So in that objective, I think this KUPOTA will really go a long way in helping all the students to attain one minimum level of basic standard. And yeah, it was very good interacting with Dr. Prakash sir and Dr. Bindu, Dr. Anand. It was a very nice initiative. Thank you.
Thank you so much, ma'am. Anand sir.
Ma'am, I felt like I'm undergoing an examination. It was, in fact, we are stuck with the retina all the time, and we are just like we've forgotten the orbit part. But I think with today's discussion, it was like revisiting the olden days, and it was also an eye opener for us also to think in different ways. As the experienced Prakash sir and Kavita madam and Bindu sir and Chinmay madam, we have. So Bindu madam. So they've been very good discussion that we had, and of course I would like to thank Soumya madam, and Mahesh sir. Sorry, Mahesh sir was about. I mean, he was going for another CME. He could not continue here, but he has been instrumental in all throughout, and. Of course, he's also busy with elections. We would like to see him in winning the AIS elections. I would like to take this opportunity as well for making a request for that. And of course, this discussion was really fruitful and very useful for all the PGs who have attended. I hope all the PGs in future also they're going to take part in all these kind of discussions, and more the staff are going to be part of it in future. I'm grateful to Soumya madam and Mahesh sir and everyone for being giving me opportunity. Thank you, madam.
So thanks. Nice meeting you, sir. Thanks for chairing the session.
My pleasure, sir. Thank you, sir. Same
Yes,
to you.
it was nice to get to know you, sir.
Yes, sir.
Same.
Thank you everyone for this pleasant opportunity, and my heartfelt appreciation to Dr. Mahesh Babu sir, the mentor Chinmay, presenter Karishma, and all the esteemed faculty PG examiners for elevating the discussion through this thoughtful questioning and insightful guidance. And a special word of appreciation to our presenter because she really prepared well and faced all the questions with such calm. I guess that will just carry her forward to the postgraduate exams. To all the very best to you, Dr. Karishma. And then I
Thank
extend gratitude to our digital partners, Clarinet, Ritu, and Swastika, who have really helped us to smoothly execute today's session and having helped us plan this session also. And then today was more than a case discussion, it's a beginning of a collaborative effort. So thank you all once again, and we look forward to seeing you at the next session. Have a pleasant evening. Thank you so much. Thank you everyone
Thank
once
you.
again.
Thank you
Thank you,
all.
Thank
ma'am.
you.
Good night.
Thank
Yeah,
you.
thank
thank you.
Thank you, sir. Thank you.
Thank you, ma'am.
So, thank you so much, ma'am and sirs, for joining with us today. And I really hope that you all had a seamless experience. So, with everyone's permission, I'm concluding the session in here for today and looking forward to host you again. Thank you so much.
Thank you so much,
Thank
Swasti.
you.
Thank you. Good night.
Good night.
Thank you.
Thank you.